Like we have a very good turnout this morning. I think since we have, looks like quite a few people here, we can go ahead and get things started. So I would like to thank everybody for coming to this Zoom, and we look forward to the information that Dawn Laney will be able to provide an overview of highlights from the recent World Symposium. And I think most of you probably know Dawn Laney, but she is a genetic counselor with Emory University in Atlanta, Georgia, here in the United States. Also very well versed on Fabry disease and the various research projects that are going on, clinical trials, and just working with the Fabry community for so many years. She is definitely a Fabry expert. So, with that, again, thank you. And Dawn, take it away.
Thanks, Jack. I appreciate it. I am going to make sure I can show you the right screen here. All right. Are you seeing the full screen with no notes or anything?
Yes.
Perfect. All right. Thank you. Well, so I'm so excited to go through some things with you guys today. If you haven't heard, the World Symposium is a big meeting that's focused just on lysosomal storage diseases. It happens every year, and people from around the world come together, both some patients and people who work in the laboratories and doctors and all the genetic counselors. Everybody gets together just to talk about different lysosomal storage diseases. And so I go and I learn about all these things, but I also try to pull out key points that I think will be useful for you guys as we move through. So here are my disclosures. I do talk to a lot of people about Fabry disease and do a lot of research. My real goals, though, are to give you some key pieces of information about Fabry disease that I learned, and that hits therapies, that hits just general learning about Fabry disease, and it learns about future things that we're thinking about. I have to tell you, the best thing about going to the world meeting is watching all of your advocates and the people who are out there moving and shaking to bring better representation of Fabry disease to everybody in the world working in Fabry disease. So this is just a few pictures of all the people working hard for you at the world meeting. My review here, I want you to feel a little bit like you were joining us at World in these big poster sessions that happen over 3 nights at the meetings where we sit and learn from big presentations. And then we also have little breaks in between. And what you see here is in that meeting room is a break in between. And you'll notice that just naturally over time, all the genetic counselors working in Fabry disease and lysosomal storage disease have clustered in one area of the room. And there's a few other places too, but I thought this was really fun because we were having a chat in between sessions
Hello,
here, and there were just lots of.
Dawn.
Yes, Jack.
Sorry to interrupt. Your
Yeah.
slides are not advancing.
Oh no. How about this?
Yes.
All right, good. Okay, so this is all your friendly faces working hard for you. And this is what I was mentioning with the meetings and the posters. All right, so the first poster I wanted to talk to you about was a poster that was focused on what was happening with you guys. And this is a survey that went out to people with Fabry disease in US and Canada. And what they were looking at is trying to figure out what kind of symptoms are lingering in women with Fabry disease at this time. And over half of women reported on symptoms that are things that you have to ask people about. So burning pain, fatigue, and GI symptoms. And I know that's probably not a surprise to you, but it underlines that we really need to do those surveys that people fill out to learn more about what is happening in people and then address those from the surveys instead of just only relying on assessments like echocardiograms and EKGs. Again, this is not a news flash, but I think it's important to underline that it needs to be done in women and men, and that we need to really listen, and physicians need to understand what's happening so they can address it. The other point was that several things came up that told us that there are still barriers to good communication in between patients with Fabry disease and their doctors. One particular area that we get concerned about in the United States is people who lived in underserved regions. So that would be people who live very far away from major cities, or people who are not white in the United States can sometimes have additional barriers to care. And so Elena Lim, who's a genetic counselor who works here with Fabry patients at Emory too, she is working on a study trying to figure out what those are so we can try to fix them so people can get to therapy and have better experiences with diagnosis. This one is a study that I thought was important. Rachel Lynn here is someone who works with Fabry Support and Information Group under a project called Testing for Tots. And she goes through the United States and submits Fabry disease to be done for newborn screening. And each state in the United States decides for themselves whether or not they will test for Fabry disease. And she went through the list of requirements that a disease needs to have before different people will add it to newborn screening. And she proved here that Fabry meets all of the requirements. And therefore, she has the argument that it should be on newborn screening everywhere. So take it with a grain of salt, because different states are still going to decide for themselves, different countries still are going to decide for themselves. But this was a nice thing to see, that at least when you go systematically through each point of something that what you need to start screening or what is important to have before you start screening, she met them all. One other thing that I thought was really interesting were two posters. One of them was out of Taiwan, and one of them was out of, I don't remember which country it was, but they looked at people who have kidney disease and Fabry disease, and those who have the same gene change or different gene change, and try to figure out if there's different changes within the genes or different variants within the genes that increase the chance that you'll have worsened heart disease or worsened kidney disease. The Taiwanese study looked at people who have the common splice site or common change that's really common in causing Fabry disease in Taiwan. And what they found there was they found a few things that made it less likely somebody will have rapidly progressing heart disease, and some that made it more likely, whether it's a rhythm change or an enlarged left ventricle. And so that's something that maybe we should look at a little bit more in people who have all different types of Fabry disease. The other piece was looking at a mixed group of people with different causes of Fabry disease, different variants that cause their Fabry disease. And they found this particular SHROOM3 gene, different changes can make it more likely you're going to have rapidly progressing kidney disease. So I just think this is just kind of giving a glimpse into how we're going to get better at individualizing treatment and making sure that we understand a little bit better who's at higher risk to have faster progression of Fabry disease. You know this. What is the fastest way to diagnose somebody with Fabry disease? It's to look at their family members. But this was a nice poster that talked to us about how can we make it easier for families to access testing or get diagnosed with Fabry disease. And there's a project out of the UK where they are getting permission from the person who got diagnosed with Fabry disease, we call that the proband, and then directly contacting other family members. In the United States, we can't do this with our privacy laws right now, but the UK, they got permission to try it out. And in other countries like France, they're required to do this. So every country has a different perspective on this, but what they're trying to do is do a better job of finding people who are highest risk for Fabry disease because they have family members, and then trying to get them access to testing quicker so they can get treated and monitored most appropriately. Something that came about, Nadine Henderson, who's a genetic counselor who focuses on Fabry disease and other genetic conditions at University of Pittsburgh, emailed me and she's like, Dawn, have you had patients who had sudden hearing loss in one ear? So not the progressive decline of hearing, but hearing loss in just one ear or the other ear. Have you seen that more in Fabry disease? Because she had two patients who were younger who had this happen. And I said, you bet I have. And then we looked into what people have done for treatment, whether it's taking pills that are steroids or injections in the eardrum of injectable steroids or chambers where they have high levels of oxygen. And she put together a case study that says, we see this a little bit more, maybe we need to investigate it more. And how quickly, if you get treatment, is that something that's going to help restore some of the hearing or is it not? Now, you can have sudden hearing loss just as an average person. But based on what we're seeing, it looks like it's a little bit more common in Fabry disease. And of course, always it's important to get treatment as soon as it happens to see who we can get some hearing restored through different ways. Why does it happen more in Fabry disease? We don't have that answer yet. But first, we'll identify the problem. Then we'll talk about what seems to be working for treatment. And then we can look at mechanisms too. And she's now going to work on a paper, so something that's bigger and looks at more patients. I thought this poster was really great. It is a group and they focus on education and trying to bring awareness to rare diseases. And they did a study to say, do you want to see just average photo models in your education brochures about different genetic diseases? Or do you really want to see patients who have that genetic disease? And the answer was people who have our genetic disease, please. And the reason for that was multi-leveled. One is because then you see others who look like you and you feel like you're part of a broader group, because that is true, as we know through Finn and other Fabry groups. But at the same time, it needs to be respectful. So the bottom line was, yes, please show people who have the condition when you're trying to educate us about our condition, but also do it in a way that's respectful. And can understand, and so people can understand what differences might be in appearance or just how you look. And in the past, I'd talked with somebody about this. And the other thing they said is don't make everybody always smiling and happy. When you have a condition, a rare disease, you're not always smiling and happy. So we don't need our brochures to have smiling, happy people all the time. Familiar face right here. There's a great poster that we put together that Mary is the lead author on that really tried to understand a little bit better where are the breakdowns in communications between patients and their healthcare providers or doctors, and where do these things happen and what can we do about it? And one of the major things that came out of that we can do is more involvement of advocacy. And by advocacy, I mean Finn, I mean country-specific support groups, I mean trusted information going from support groups and how to empower and help you talk to your doctors. And how do we give specific resources? And then, of course, how do you give support, both emotional and educational wise, so that if you are having difficulties or questions for your doctor, how do you present that in a way that makes sense to the doctor, but also gets you the responses that you would like to get? And so we talked about, what are next steps, developing a toolkit, working with different groups to make great things. And at World, there is this amazing, wonderful brochure, we call it a white paper, that's about women in Fabry disease, that has beautiful pictures of people living with Fabry disease and helps basically talk about things we need to think about in communicating with Fabry disease with doctors and others. So if you have a chance, definitely ask Mary and Anna for a copy of that one. The next set of studies are ones that are really important, but they're not particularly cheery. We looked at Emory, and then they looked in the Canadian Disease Registry to learn more about people who started treatment later, Fabry-specific treatment later. How did they pass away? How did they die? And we learned several things that are really important for monitoring people who are later in life with Fabry disease, or who started therapy when they were more progressed in Fabry disease. And there's a couple lessons learned. One is we need to pay more attention to edema and infection. In both the Canadian group and the group we did here at Emory, there is a population of people who had a lot of edema. They had a lot more nerve damage from neuropathy in their feet, leaving them to be numb, and then led to, over time, serious infections in their feet that then led to all body sepsis or infection that led to them passing away or dying. And so we need to talk more about good foot care and looking at feet just like you would if you have diabetes and have nerve damage from diabetes. We need to also do that. We need to work hard to look at different solutions for treating edema or swelling that gets really big in the feet and legs. The other thing that was interesting is that the heart is definitely still the major cause of death for patients who started treatment later in disease course. But there was one aspect of heart disease that was a little bit different, and that was the rapid change from a aortic valve that was sort of moderately having problems to severe or profound over a very short shorter period of time than we'd expect. So that somebody who could have had surgery when it was moderate and didn't quite meet the criteria, less time than we expect later would end up with massive disease in their valve that kept them from getting surgery. And we have a couple case studies that were on the poster that showed that change and how quickly it progressed. It told us that cardiac MRI does a better job of seeing how severely affected that valve might be, and a better job of watching it progress faster than maybe an echocardiogram. We also saw that sudden onset of severe shortness of breath of fatigue that's more significant than it was in the past means you probably should look a little bit closer at that aortic valve. And there are non-invasive ways to replace that aortic valve if you catch it early enough and there's not enough additional health problems throughout the body that are causing issues. There were also things that we saw that tell us we need to do monitoring like we do for every other person in the general population. We need to do cancer screening, so mammograms for breast cancer, colonoscopies for colon cancer, things that we would do in the general population. Now we need to start thinking about more with people with Fabry disease, because in the past we're all focused on the kidneys, we're focused on the heart, and we forgot to think about high cholesterol and coronary artery disease and increased risk for cancer as you get older that everybody has. Oh, the one other thing I wanted to mention is that there is increased risk for depression and the increased rate of suicide in individuals who have more advanced disease. And both Canada and in the US, we did see some patients who really would have benefited from earlier support and therapy, and maybe medications that could help with their severe depression. And then that maybe could have helped us avoid suicide, or in Canada, they also have assisted medical assistance in dying, which we don't have in the US, but several patients who were severely progressed in their disease had that as well. Okay, changing gears, let's talk about therapy a little bit. Just to remind you guys, there are certain things we want to see when somebody is having therapy that's specific for Fabry disease. We want to see the Fabry-specific biomarkers. We call them lyso-Gb3 or lyso-GL3 or GL3 and GB3. We want to see those levels go down when you're being effectively treated. Now, if you're an adult on therapy and you started as an adult on therapy, those will probably never get to zero. The only people we see have their GL3, GB3 levels go all the way down are children who started therapy early. So, but we want to see them go down. We'd never want to see them go in a straight line up, like a diagonal up when somebody starts therapy. We never want to see them not change if you didn't after you first start therapy. We do want them to be stable if you've already been on therapy and you're switching from one therapy to another, but we don't want to see them go up, and we don't want to see no difference at all when you've never been on therapy before. The other thing we want to see is we want your symptoms to go down. We would like to have less GI pain. We'd like to see less burning pain in your hands and feet. Again, it may not be zero, but we want those to go down. We want to see the protein in the urine go down. And often that means having other medications on board as well, like an ACE inhibitor or an ARB, which we see as blood pressure medications, but they help with treatment. We see those go down if you do them together for the protein. We want your eGFR to go down just like everybody else in the population. Everybody's eGFR, or how well your kidney is filtering things, goes down just a little bit every year as you get older, after about 30. In Fabry disease, it's a steeper decline, and we want to make it more like the average people, right? We don't want to be just like them, slowly going down. When we look at the heart, we want the left ventricle, we call it the LVMI, whatever. Just think of it being like how big the left lower part of your heart is, to go smaller or be stable. So this is what we want out of a therapy. So as I go through all these different studies, that's what I want you to be thinking about. One important point that was brought up by several posters, a variety of them looking at all different types of diseases, and when you change therapy from one therapy to another, no matter what it is, you still have to do additional monitoring. You need to look at those lyso-GL3s or lyso-GB3s more frequently to make sure they're not going in that upward diagonal that we don't want them to go upward in. And you also need to make sure you're talking to the patient about the subjective symptoms, and maybe even do some other things like the echoes, the EKGs, things like that. The reason that you do that is because not everybody is the same. Different people will respond to different ways to different medications. Even with Fabry disease, even when you're trying to do the exact same thing for every person, you've got to monitor it. For example, there were a couple patients who, when you looked at the cells in a Petri dish, then their changes in their gene, their variants, were considered amenable to megalostat therapy. But when you monitor them, you found they were not. Their lyso-GL3, their lyso-Gb3 went up in that diagonal. Now it's rare, but it can happen. And that's why when you're switching from one therapy to another, you want to make sure that you're monitoring your biomarkers and your other markers really carefully. The other thing to know about is every country, and then across many countries, there's a ton of different what we call registries or patient-reported or patient outcome surveys or natural history studies. Many of you participate in these, and I thank you for that because the entire job of these registries is to get enough data across different people with Fabry disease to learn from them. And I've got a bunch of studies that are coming up next that we've been able to learn from your willingness to participate in these studies where there's no therapy. It's just, they're just following you and seeing what's happening, or maybe doing a few extra studies. This is all about looking at the data. And the more data we have, the more we get to learn. One example of this is the Follow Me Registry, which had a poster at World, and they were talking about over the long term with people on megalostat, for those over 12, how do we see things with their kidney and their heart? And what we found is they are stable over these 5 years that they looked at. Now that's on average, right? So maybe some people went a little bit up, maybe some people went a little bit better than this, but on average, what they saw is that things were stable and there were no safety findings they were worried about. That's what registries can tell us, like overall and the patterns of things that we see. There was a similar series of posters that were out of different countries. Each country had a slightly different focus. One of them is something they had to do after it was approved in Korea for use. They had to do this long-term study. One of them is a Follow Me database. We just looked at the data, but they focused on just patients in Spain and Portugal. And one of them is a Canadian-specific disease registry that's been going for a long time. When we looked at all of these things, there was no increased safety concerns that were found with people on taking megalostat. And they did find some stability or improvements over time in different markers, such as those biomarkers we talked about, such as, how big the left ventricle was and what the kidney filtration, that EGFR looked. There was also something that was looked at in Canada, which was looking at the rate at which people have severe events. So that would be strokes, kidney failure, dialysis, arrhythmias, constant angina, which is that heart pain, death, strokes. And they found that Fabry clinical events like that occurred in 25% of the patients on the medication. And in other studies, they compared that to people who've never been on therapy or people who are on enzyme and things like that. It was not higher. There was not a concern there. It was just important to know that even when you're on therapy, you can still have severe events. They also talked a little bit about a study that they're doing where they're looking at taking Galafold in young children who are under 12. So there was no data they gave. They just said that they're enrolling in different places, and we'll see, because depending on the size of children, you need to know if you have a different dose of megalostat. They also reported a little bit of data, the first parts of data, in looking at people who have kidney disease, who have EGFRs, those filtration rate that's lower than what that is currently approved for use of megalostat. And the reason for that is when you look at how megalostat works, you've got your enzyme, it's got an active site, and for people who are amenable to megalostat, if they've got a good enough enzyme that when the chaperone binds, it allows that enzyme to be refolded a little bit so it works better, makes it through quality control, gets into the lysosome, breaks down things, and then needs to leave. Well, it binds in the active site in a way that if you gave too high of a dose, then that medication wouldn't work the way that you wanted it to. So if this medication is cleared through your kidneys and your kidneys aren't working well, we need to know what dose should people be given. So the study that they're working on was looking at different length of doses, so giving it once every 4 days, once every 7 days, or once every 14 days for people who had lower kidney function or were on dialysis, and figuring out what was happening. So what they found is there's not too much Galafold or migalastat building up. And that's the first thing they told us. So with these doses, it's not completely making it the chaperone unable to work the way it needs to. So that's nice news, but we don't have any other details yet. The Fabry Registry put out a publication. Again, one of these studies where like, yes, we know. But what they're saying that was very interesting is they're saying, okay, many people, when they are diagnosed with Fabry disease, have burning pain, neuropathic pain in their hands and feet. But often it also, at the same time, you're seeing organ damage or issues with the organs already. But what was even more interesting to me is a lot of times with non-classic Fabry disease, we talk about it being heart focused or kidney focused. But this study showed us that people with non-classic or later onset Fabry disease, 27% of men and 30% of women are having pain. So we can't say something is just heart focused if people are having pain. Is it everybody? No. And this is in adults. But if you look at the amount of patients who are considered later onset who are having pain, it's more than the general population. And that's something we need to think about for monitoring, for treatment, and for how we talk about later onset Fabry disease. And you can see that also interesting to me, if you look at the peripheral pain at diagnosis, both men and women, 50% have pain at the time of diagnosis. So can't say that women have less pain in this particular study. Good to know, right? Let's talk about early treatment. I talked a little bit about early treatment and how when kids begin therapy, sometimes we can get those biomarkers, that lyso-Gb3, that lyso-GL3, that GL3, down to 0, and how we don't see that in adults. So there are 2 studies that were done and presented at World. One of them was here at Emory, and we looked at all of the, well, it was a study across the United States and Canada, and we asked people who are now over 18 who have classic Fabry disease and are men, what was happening when they first started therapy and how they feel therapy has changed over time when they started therapy under 18. So they had to be a kid when they started, and now they have to be an adult. So what did we find? Well, we found a lot of things, but the summation is the majority of the patients had improvement of some or all of their Fabry symptoms that were there when they started. That was 87% of them. And 93% felt that being on enzyme positively changed their disease progression. And we have medical records data on many of them. So we're looking at things like their kidney function and things like that. But I thought it was really important to hear what they said, because if you only just go on the objective data, we're missing that piece that we're using as a theme for this meeting, which is you have to ask people and understand where people are feeling and what pain they're having that you can't measure from a test. And so that's what we combine in this study. The objective stuff you can measure from medical records with the things that people tell us. And that's what they told us. There was also from the Fabry Registry a broader analysis that was many more people than we're able to do in our study. And this one just looked at the data that was entered. So this one didn't have as much perception of how things had changed with enzyme replacement therapy, but it did have some important lessons for us on the actual physical findings. So this was kids who got diagnosed at about 5 to a teenagehood. They started therapy when they were around 11 on average for both boys and girls, but they had a delay from time of diagnosis. So between symptom onset at around 7 to actually starting therapy at about 11, still reasonable, right? But again, just showing that there's a delay between these things. The biomarkers, remember, we want them to go down, and that's what they saw in both boys and girls in plasma lyso-GL3 and just regular GL3. We saw it from a high to going down to a low. And again, that's what we want to see. And then we saw that in everything. So that was good. The one thing I want you to notice here is that not all girls will have elevated lyso-Gb3 or regular GL3, even though they have symptoms. So that measurement is not always great for girls. And that's why you don't see as big of a change because many of the women didn't have abnormal GL3s or GB3s when they started therapy. It's just because of that exon activation thing where we've got different levels of enzyme and GB3 throughout our body. It doesn't correlate with how severe a woman's symptoms are. This is really busy. I don't want you to look at all of it, but I want to tell you two summary things. The thing I like about this is it shows that when boys and girls had pain before they started therapy, like the burning pain in the hands and feet, it is not all going away, even with early therapy. Just think about that for a second. We're looking at the youngest kids that we're able to measure during the registry, and most of them did not have massive improvements in pain. That's sad, right? But then I want you to look at the pain crisis, where there's huge improvement. So even though it's not happening necessarily with the day-to-day pain or burning pain, it is greatly helping with pain crises, greatly less. And abdominal pain, it's also making big changes. So it tells us, at least in my mind, that we need to start therapy before pain starts in our kids. If we are able to not necessarily improve those with enzyme replacement therapy, then we have to use additional medications to improve their pain sensation. But if we started before they had daily pain, would this graph look different? I don't know, but from some early data that I've seen, I think it does make a difference. I think we need to start therapy for our kids with Fabry disease before the burning pain. So that's my summary from that busy slide. We also looked at, were people having some of those events I told you about? Were kids having strokes? Were they having heart attack? Were they having arrhythmias? Were they having death? Were they having other things? The age at first event, we had some events, right? Not as many as it could be. We had some events though. And what they saw were basically heart events. So there was some that had a rhythm into their heart, atrial fibrillation or ventral tachycardia. We have a couple with chest pain. And then there was one that had a TIA. But those events were happening in the 20s. So again, with the theme that sometimes you can't stop some of these events from happening, even if you start therapy. Okay. Let's talk about another survey. This is the Fabry Outcome Survey. This is another like a registry long-term. And this was one that's got lots of data. Our two Fabry Outcome Registry, a survey, and our Fabry Registry have lots of data over 20 years now because both those medications began the registry about the same time. So Dr. Darylyn Hughes did a lovely presentation that showed that long-term outcome with agalsidase alpha for over 19 years was associated with favorable kidney, heart, and other significant health issues, and generally well tolerated. So, you know, there's a lot of people in that, right? So if you look at the pictures, you're like, wow, that's a lot of people in those studies. And you can see some people are doing better and some people are doing worse. And some people started therapy earlier and some started later. But on average, the eGFR is going near the rate that the general population is. And the heart measurement on average is stable. Now, everybody's different. Everybody had better or worse based on that. But you can see when they average it out, what we see. Going back to our theme of learning from people who have passed away, one of the things they looked at was what is the probability of surviving longer than we thought it was, right? So if you ever had looked up on the internet when you were diagnosed, when the average man with classic Fabry disease passes away, you probably would have seen back in the day 40 years of life. Well, this proves that we are well beyond that now, because when they looked at all comers, they found, again, this is not, you know, to take home and say like, this is my plan. But when they looked at people who were treated, the average age of death for those who have passed away, because remember, there's a lot of people who have not passed away, was 59 years for males, and it was 70 years, 69.9 years for females. So is that a huge improvement from what we originally said without therapy? It sure is. But remember, this is people who started therapy when they're very progressed, people who have not yet, who started therapy earlier and had other things happen. I just want you to think of it as we're moving the line forward on average, even in people who started when they had a lot of Fabry symptoms. now that we have lots of options for treatment of Fabry disease, one of the questions was, how does that look? What are people doing? Who is still not getting treated in ways that we'd like them to get treated? And there's a study that came out from Lisa Berry, and she's actually doing a webinar, a National Fabry Disease Foundation webinar on the 9th, if you wanted to listen to more details about what she found. But she found that half of the people they surveyed in the US and Canada were on egalsidase beta. Sorry, half the people they looked at were on enzyme. Around 80% were on egalsidase beta. About 8% were egalsidase alpha. Remembering that in the US, we can't get egalsidase alpha, Repligal. It's not approved for us. And then 9.7% were on pig unigase alpha or elfabrio. 80% were doing such an amazing job and doing a good job sticking at their every 2-week schedule. And if they missed, it was because of a vacation or work conflicts or something like that. There were, though, 27.3% of people who discontinued therapy. Some of those is because they switched to migalastat or an oral therapy. Cool. But some of them did not, and they stopped therapy because of they thought their disease was progressing in a way that wasn't being helped, or their infusions were too long. And then there were 16.4 people who responded who'd never been on therapy. And I think it's important to dig in a little bit more on that to find out why they're not on therapy at all. There was presentation by Dr. John Bernat that was looking at long-term data for people who were on pegunidace alpha, and they were on it every 2 weeks. So these are long-term data. And what they showed is it was rare to have a serious event, and those serious events, those things I talked to you and listed out before with the heart and the kidney and strokes and death. There were some infusion reactions, but there were no withdrawals or deaths that were attributed to taking the medication or reactions. And like we wanted to see, they saw the biomarkers being stable. Remember, these are people who are already on therapy, so they're not going to go down, hopefully. I mean, they could go down, but they're not going to go down. On average, they stayed stable. We didn't want them to see go up. We just saw them stable. The kidney function was looking, the EGFR was looking better than what it had been for the people who are Fabry who are not on any treatment. Not quite for the men at the average general population rate, but still looking quite nice. So losing the slope going down was looking really good. And when we looked at the amount of people who'd been on therapy for a while and who are now doing long-term data, their antibodies were stable. So having them or not having them, it was pretty stable. They weren't going up and up and up. Bottom line, stable, looking good, long-term, not worsen safety or anything. They're doing a study in kids now to see if you could use pegunidace alpha in kids, but they didn't give results at this point. One thing that did not get presented, but the people were there to talk about it, was there is a company called GC Biopharma Corporation, and they are working on an injectable enzyme replacement therapy that you could have every 4 weeks. Now, they're right now trying to figure out the dose, and they need to figure out if it's safe. But that is a study that's enrolling now. And the nice thing about that would be that you could self-inject the enzyme if it's proven to be safe and effective, right? We're not there yet. But just know they're looking at different ways of doing enzyme, which leads us to another one, which is there was an award-winning abstract where a young investor talked about how they went through all these different types of enzymes in a database of enzymes and tried to find ones that affected the immune system less and were maybe a little bit more effective overall in levels of enzyme. So stay tuned. There was no we found the perfect one or anything. They just found some options that maybe they could test on. Okay, changing gears. This is a different type of treatment called substrate reduction therapy. I like to think of it like getting around the traffic jam. So the traffic jam in this case, all the cars stopped, would be missing enzyme alpha-glucosidase A, and everything builds up there. All those GL3s, all those lyso-Gb3s. And what we want to do, instead of causing a traffic jam with all the cars blocked behind it, is we want to use those local roads and exit early off the big highway so that it doesn't all get built up. So substrate reduction to me is directions that takes all the stuff that would build up and takes them out of the pathways earlier so you don't end up with a traffic jam at the enzyme missing. They were reports at this meeting on 2 of those. One of those is lucerastat, which is Idorsia did a study for long-term. And this is the long-term data that showed that long-term safety was good for people taking the medication. And their kidneys, when they did kidney biopsies or looked at kidneys, they didn't have any more of those striped zebra bodies that show that stuff is building up in the kidneys that cause the damage from Fabry disease. So that was great. We want to see that. So this means that they're going to move into another study. There's also a study by Sanofi doing a substrate reduction therapy that's different. It's called venglustat, and they're looking at pain in hands and feet, and they're looking at the heart in two different studies. When they're looking at the pain, they did see a reduction, but the reduction was in the placebo and it was in the people taking the drug, because this was either you got the placebo or the regular one, and they both went down. So there wasn't a clinically significant difference, but they're going to keep it going, the study, see what they see. In the meantime, the heart study is continuing, but they don't have data for us yet. Okay, gene therapy, the one that we all are like looking with our big eyes, trying to figure out what's happening with it. Remembering that there's two ways to give gene therapy. One is you give a one-time infusion that has lots of these, we call them vectors. That's just a fancy word for viruses that we've taken all the bad stuff out, but they can still infect cells. And we put in what we want to be presented to our body. So I like to think of it as you get an injection, a one-time infusion. Many times it's targeted to the liver, and the liver, you put a little circle of DNA, and that little circle of DNA makes your cells of your liver into a enzyme factory. So then that liver sends the enzyme all throughout your body. That one, we usually use what's called an adeno-associated virus, or AAV virus. There's other gene therapies out there that inject something similar, but they integrate it into your own DNA and try to fix it there. We don't have any of those in Fabry disease. There is another type where you take cells out of somebody's body after dampening their immune system. You transform the cells the way that we want them, fixing the GLA gene so it makes its own enzyme, and then you give the people back their cells. There's one that's been ongoing for a long time with that one. It's called a lentivirus, is the name of the virus that we use to do all that. But just know there's two different kinds. You remember what we want to do when we have therapy? Well, with gene therapy, we also want to see the levels of alpha-galactosidase in our body go up in a big way, as well as all the other things we talked about with the other therapies. They presented long-term data on one study. It's called the FACT study. This is the data and the original things that then AvroBio took and then took around the world to do more studies there. But this is the first 4 original Canadians who went under this with the same protocol that they had developed in Canada. They found that over long-term times, all the things that we thought we wanted to happen happened. Their heart stayed stable or the level decreased. The slope of their kidney function, their eGFR, continued to go down in a way that's much closer to what the general populations would be, so what everybody else's would be. Their protein was not as significant as it had been before, and they didn't have any of those serious adverse events that we talked about in other studies we've been thinking about. So in general, GB3 was down and then stable, and the safety looked pretty good. Now, this is really long-term data. If anybody was aware of the AvroBio studies that happened in Australia, they didn't have the same kind of results, but that wasn't presented at this. And AvroBio is no longer running this study, although they are looking at ways to bring back this technology in Fabry disease with a different company. Sangamo is a company that did a AAV gene therapy. They were able to present some longer-term data here. This is one of those ones that you infuse and it targets the liver cells, making your liver into a little alpha-galactosidase enzyme factory. They had multiple patients. They had men, they had women, they had those who switched from one therapy to another. They had people who were on therapy for the first time. And so I'm going to show you 2 different graphs here. This first graph we're looking at, the top one is people who'd never been on therapy before. And the enzyme levels that they had were low. So think about it in 0. And then they went up after they got their enzyme. And you can see everybody's went a different amount up. That pale blue line you see there between about 5 and about 10, that's what an average person's alpha-galactosidase would be. So if we measured mine, I'd be in that level. And you can see most of these patients spent a lot of time way above that level. So that's good to see. Now, if it's just high in your blood, does that mean it's helping your body fight Fabry? Not necessarily. So we have to look at some other things too. So the lower graph is our plasma GL3. And remember, these are people who'd never been on therapy. So we want it to go down, except for the women, which sometimes have normal levels and they can just stay stable. And you can see some people went down real low. Some people went down but didn't go as low as you'd want. And again, remember what I said about being an adult with Fabry, you don't always have your levels go to zero. But it was pretty amazing to see all those levels go down quite nicely. Although you see that one blue line that was just stable all the way through, that's still in the lower levels. So that could have been a woman with Fabry disease. I don't remember which one that was. How about people who were on enzyme, Fabrazyme in this case, I believe everybody was. And when they switch, what happens? Well, some people got so much enzyme, they had to make it upper level of the graph, right? So you see that one person with the red line at the top graph, and their enzyme level is so high, they had to make a break in the graph and then do it up. Other people, not so much. So you'll see one person with light blue down there at the bottom who didn't respond the way they wanted. The plasma GL3, again, these are people who are already on enzyme, so we'd expect them to stay stable. We're not really expecting to go down. And you can see that one person whose enzyme levels did not increase is that same person whose GL3 levels did increase. And that's because he may have gone off enzyme replacement therapy, and you can watch those levels go up, up, up. So that's what we don't want to see. Now, if the infusion of the gene therapy didn't work, then that's when we would see the lyso go up. But everybody who had it work, which would be everybody else, their levels went up. So they also saw improvements in kidney function. So using this data, they are applying to the FDA to get this approved for use as a clinical marketed product. They're going to be doing that over the course of this year. I don't know how long it's going to take. I don't know what the FDA is going to say, but this is the closest we've gotten Fabry disease to having a gene therapy that's available. And the safety profile was really good. Some people had liver functions that went up and they had to be treated with steroids. Some people had just various symptoms during the infusions, but nobody had life-threatening responses, which is what we always worry about in Fabry disease, that the immune system will get really irritated and cause massive systemic reaction, which wasn't seen. This is my favorite part of it all, though, because remember when I talked about we want to ask people what's going on with them and how we need to ask directly before we know what's happening. This is that score. And what it showed is people who were green is when they start, before they had gene therapy, whether they were off therapy entirely or they're on an enzyme, and moving out for everybody. Everybody had improvements in global function across everything. That's pretty cool. There's another gene therapy, same thing, infusion over time, one-time infusion, going to liver, making the liver cells, made out by Unicure. It's a different type of gene therapy, even though it's not adeno-associated virus. And it's earlier stages, right? So they're currently still trying to find the dose. This is only in men who are stable on their enzyme replacement therapy. Their alpha-lactosidase levels went up. You can see they've got 3 different doses they were trying out, and you can see that they all led to different amounts of alpha-lactosidase A going up. You'll see there's one person who didn't respond. You can see that down beneath. In this case, that green bar is what an average person would have who didn't have Fabry disease. So you can see the most effective doses that you're looking at here would be that high dose or that middle dose, but even some people responded really nicely to that lower dose. So this is what they found. Now they need to decide what dose they're going to move forward with and then figure out how effective it is. But in the meantime, they did provide this data that shows that lyso-Gb3 was either stable, remember they're all an enzyme, or went down a little bit. And their safety looks pretty good. Again, they just like the other one, they had some people who had elevated liver functions, and they had some people with some events not related or possibly related, such as some chest pain or some enhancement in the brain. No massive systemic response from the immune system in this one either, so that's good. So that is my rapid fire zooming through some of the things I learned at World. Hopefully you saw some of the themes that I found there, which is that people are listening to individuals with Fabry disease so that you can learn more from you about how you feel about therapies or how you feel about things that are happening in your lives or how you feel about just in general communication. I would love to hear what you guys think, any questions you have, anything you want me to go in a little bit more detail about.
Anybody that has questions can type